Good morning, everyone. Welcome to NADO 2020's Day 3. We've had some interesting developments over the weekend, and we are hoping that this technology solution that we're providing for you today works smoothly and without any hiccups, and we are confident that we will. We'd like to just mention a couple of announcements and reminders. First is the Daily Puzzle. Reports from Daily Puzzle number 2 are due by 1 o'clock, and we'll do the drawing promptly at 2 o'clock and announce the winner on the platform in the lobby. We also want to remind everybody that we have an exhibit hall. We have some fabulous exhibitors who have some great things to share with you, and we would encourage you to join them at the exhibit hall. Today's opening plenary session, the Host State Showcase by the state of Massachusetts, is sponsored by Friedman Healthcare, and I would like to introduce John Friedman of Friedman Healthcare, who is going to give a few remarks. John?
Thank you, Norm. Good afternoon or good morning to everyone. I'm John Friedman. I'm delighted that Friedman Healthcare, a Massachusetts-based firm, has the privilege of sponsoring the kickoff of the second week of NADO 2020 with a virtual showcase of our own home state. We are lucky and we're proud to have such a collection of leading state agencies, nonprofits, and commercial entities all working for better healthcare. So with that, let me hand you off to our host this hour, Craig Schneider of Impact International. And welcome back, everyone.
Thanks very much, John. Greatly appreciate that and your sponsorship and support of NADO. I'm Craig Schneider. I'm a managing director at Impact International. We're a consulting firm that works largely with federal agencies, but also with state agencies and foundations. And truly my pleasure to be the moderator for this session of the Massachusetts Showcase. Of course, we wish you could join us in person, but I think we've adapted nimbly to the virtual world. So when we were thinking about how to do the showcase, one of the things that makes Massachusetts unique is the constellation of nonprofit organizations we have in the state that are involved with health data, health information technology, health information exchange, and quality improvement work. And in fact, one of my previous positions was at Massachusetts Health Data Consortium, one of those organizations that you'll hear about today. And I actually wrote a guide to all these organizations because there were so many of them, and there was a bit of confusion in the community about who was doing what. So here today, you'll hear sort of an oral guide to a number of these important organizations that really contribute to what makes Massachusetts special in the healthcare space. So when we were planning the session, we thought it'd be interesting to highlight these organizations along with the Center for Health Information and Analysis, which is a Massachusetts state agency, and you'll hear shortly about that organization and its roles. And CHIA, as it's affectionately known, is the holder of the inpatient discharge database and the all-payer claims database for Massachusetts, among other data resources. So that's the panel we put together, and we're definitely grateful to the panelists for their time and interest and support of NADO. And I think we're gonna have a really informative discussion today. So I'll give you a brief introduction to who the panelists are, and then we'll go right into a series of questions when we'll get to hear from each of them. And then there should be a little bit of time at the end for general questions and answers from anyone in the audience. So we've got Ray Campbell, who is the Executive Director of CHIA. Paula Griswold, who is the Executive Director of the Massachusetts Coalition for the Prevention of Medical Errors. David Martin, Executive Director of the Massachusetts Health Council. Denny Brennan, who's the Executive Director of the Massachusetts Health Data Consortium. And Jim Cordemanch, not the Executive Director, but an important official, the Vice President for Programs and Analytics at Massachusetts Health Quality Partners. So the first question we want to hear from each of the panelists to inform the audience is just please tell us about your organization, what you view your role as in the Massachusetts healthcare system. What is your mission? Who are your members? Who are your funders? Just that sort of basic level setting so people can get a sense of what your organization is and what you do to improve health and health quality in our community. And why don't we start off with Ray?
Thank you, Greg. It's a pleasure to be here on this panel with these panelists and also to be participating in a NADO event. Again, it's been a number of years, but a great organization. I'm really happy to be back and participating. And a really interesting set of issues to talk about this afternoon, so I'm looking forward to that. In terms of describing CHIA, we're an independent state agency with regulatory authority. We have the power to compel participants in the Massachusetts healthcare system to submit data to us. We use that authority to collect large amounts of data that we curate, and we use that, we take that data and we curate a number of major databases. That data in turn is used by CHIA to create a lot of metrics and reports. It's used by a lot of our sister state agencies. Our data is shared widely within state government. It's used by the legislature, by the Attorney General, by the Auditor, by the Health Policy Commission, the Department of Public Health, the Commonwealth Connector Authority, Mass Health, the Executive Office of Health and Human Services. So extensive use within state government. And then the data is also used externally by researchers, by provider organizations, by payers, and even by the multi-stakeholder nonprofits on this call. So we feed into the data ecosystem in the state. We're very happy to be part of that. It's, our first priority is the policy-making realm, but we do everything that we can to try to be a very responsible data sharer with all of these great healthcare organizations in Massachusetts. Data really helps them do the excellent work that they do, and we try to take it very seriously, our responsibility to share with them as much data as we can. So in a nutshell, or just briefly before passing the baton, I said CHIA curates a number of databases. At a high level, let me just briefly say, so we have case mix data, which is the hospital inpatient discharge database. We have an emergency department database and an observation stay database. So between those, we see essentially all hospitalizations in the state. We also have hospital finance data that we use both for rate setting purposes, but also for just assessing the financial condition of the provider organizations in the state. We have an all payer claims database that we can certainly talk about more if people are interested. We collect lots of aggregate data from health plans. We use that for, among other purposes, to create our measurements of total healthcare expenditures and total medical expenditures in the state. A lot of people think we may use claims data for that purpose. We don't. We require any health plan that's active in Massachusetts to report to us on what they spend. We work with actuaries to build a picture of total healthcare expenditures and total medical expenditures. And we also break that down into its major constituent categories of inpatient, outpatient, physician services, drugs, and so on. Just this year, we're adding a new dimension of that. We're going to be collecting information on how much is spent on primary care and behavioral health services. We want to start understanding those segments of healthcare spending in Massachusetts. So aggregate payer data is very important to us. And then lastly, I'll mention survey data. We do two really extensive and really excellent surveys. One is a household survey where we ask people about their insurance coverage, the choices they make, and a lot of issues around affordability and affordability of insurance and access to care. And then we do an employer survey where we extensively ask employers about employer-sponsored insurance, the reason they make the decisions they do, uptake by their employees, and things like that. So CHIA is, we are a health data organization through and through, and very happy to be part of NADO this year. I would like to do a shout out to Kathy Hines from CHIA, who's on the board of directors at NADO and does excellent work for both organizations. And there's a bunch of people from CHIA that have worked on the program committee for this conference this year. We're very pleased that they were able to lend a hand.
Great, thanks very much, Ray. Paula, let's hear about the coalition and the work you do.
Thanks, Craig. And again, I'm also delighted to participate with this impressive panel today. Our coalition is a multi-stakeholder membership organization. We're a 501c3 charitable organization, and our members share the goal of improving patient safety, and we've also been emphasizing healthcare workforce safety in Massachusetts. So our members include provider organizations and their associations for hospitals, long-term care, physicians, nurses, pharmacists, nurse leaders, as well as state agencies, consumer groups, health plans, malpractice insurers, education organizations, researchers, and others. So a really broad membership. Among our members and funded by their membership dues, our role is to help our members learn effective strategies to improve safety from each other and from other organizations around the country. And then we also help our members align efforts with each other and communicate across those settings to improve their own results. So provider organizations have a chance to talk with the regulatory agencies, with the health plans, with the researchers. We have a chance to learn from the malpractice organizations, all toward more effective approaches to improve safety. So then in addition to that, we regularly pursue grant funding for periodic statewide initiatives to improve patient safety. And for those, we recruit participants statewide. That's not just restricted to our membership. We organize improvement collaboratives to help those organizations implement changes that would make substantial progress toward a specific goal. So we've had a broad array of collaboratives over the past 20 years for hospitals, for long-term care organizations, for ambulatory settings. And then since care physicians is also a time of particular hazard of potential for high harm to patients, we've worked on reducing readmissions across care physicians across settings. Over those past 20 years, as I say, most of those improvement collaboratives have had a specific safety goal, such as improving timely and reliable communication of critical test results within hospitals, reducing cases of potentially fatal infections within long-term care settings, or as I mentioned, reducing hospitalizations within hospitals and working across settings. Recently, and I'll comment more on it later, we focused more on overall strategies that would improve patient safety systemically within organizations and also across the whole sector. Some work that we're very excited and look forward to have a chance to comment on as well. Thanks.
Thanks, Paula. Next, we'll hear from David Martin.
Hi, everyone. Thanks, Craig. Hello to my fellow panelists. This is a great and esteemed panel, so I'm happy to join you all. I'm also, I always like talking about the Massachusetts Health Council, which I have the privilege of leading. So the Massachusetts Health Council is a 100-year-old organization. It was actually founded in 1920 in response to a tuberculosis pandemic that had broken out across the country, but was particularly bad in Massachusetts. And so the Department of Public Health and the Massachusetts Medical Society and the Massachusetts Nurses Association and a handful of other organizations got together. They formed the Massachusetts Health Council in order to be responsive to this epidemic and create treatment facilities and educate the public about tuberculosis. The group stayed together for about 50 years, and then or about 30 years, and then in the 1950s, formally incorporated as the Massachusetts Health Council and began working on the issues of the day. So if we were having this conversation in 1930, we'd be talking about milk pasteurization. And if we were having this conversation in the 50s, we might be talking about auto safety. And in the 70s, seatbelt laws and helmet laws. So the Massachusetts Health Council is a membership organization. Our members are typically hospitals, health plans, doctors, nurses, dentists, everyone associated with the healthcare industry. So we have about 130 members. And when I say healthcare industry, we try to mean, the health industry in general. So YMCAs and Boys and Girls Clubs, and all of the entities that go into creating a healthy society, a healthy place to live. And that's really what the Massachusetts Health Council is about. It's about promoting policies and programs that enable people to live healthy lives. Words that have gotten a lot more stock in the last decade as we talk a lot more about population health and the social determinants of health. And I would really emphasize have gotten a lot more salient in the last 6 months, when what we really see is poor health conditions contribute to a worse death and infection rate for something like COVID. So it is really important that the organizations like the Massachusetts Health Council and all our partners work on these large health system reforms, to really make a difference in people's lives. So that's really who we are. I know the questions are sort of, our role in the healthcare system is this advocacy and program promotion role. So for instance, a big topic for us has been around sugary drinks, running a healthy beverage campaign in schools, for instance, where we will recruit school nurses and students to do a healthy beverage campaign in the middle school, for instance. High school students can do this in the middle school, but also on the more policy side, we'll actually advocate for a sugary drink tax. And then the tax itself will reduce rates of sugary drink consumption, which is overall good for population health. The funds can, of course, go to things that can shore up healthy living conditions in poorer communities and communities of color, which have historically been overlooked with a lot of these things. So, however, then along comes a pandemic and suddenly sugary drinks don't seem to be top of mind for anyone anymore. So the Massachusetts Health Council has embarked on a campaign around vaccines and vaccinations to ensure, for instance, that communities of color are not left out of an eventual COVID-19 vaccine. So it's an education and engagement campaign to remind people that vaccines are safe. They're one of our great public health accomplishments over the last 100 years. But we want to ensure that communities of color are involved in the development and testing of vaccines. They're engaged in this process so they can have some trust and some faith in the process. Communities of color, as we all know, have good reason to be skeptical about their treatment by the medical establishment. So we have our work cut out for us to make sure that vaccine is available and safe throughout the Commonwealth, but in particular, in Black and brown populations. Lastly, I guess I'll talk. Our funders are, typically we do host a large award gala every year. We'll have to do a virtual version this year, but we raise funds through that. And we're a membership organization, so members, individual hospitals or associations that become members pay dues. And we're always looking for more members, so would happily recruit all of you. I think Paul is a member.
We're not. Come see me.
All right, you're on my list now.
Great, thanks, David. And now we'll hear from Denny about another type of membership organization.
Thank you, Craig. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium. Our history with NADO and with health data goes back to Elliot Stone, in whose name NADO Awards provides an annual award to individuals and organizations of distinction in the health data business. And as Ray mentioned, Ray was the successor to the late Elliot Stone, and I followed Ray. So we have a line directly to NADO via a number of channels. MHDC, as we call ourselves, we are both a convening organization, which I would say almost all of the organizations on the panel are, but we are really focused on health data, less on advocacy, except in so much as it supports the free flow of data to support, better quality, better health access, better cost effectiveness, or value, as we say. And we do that in a number of different ways. We are a membership organization, and we have members that span the health plan, healthcare provider, government, and industry sectors, as well as the associations and not-for-profits in Massachusetts and beyond. But we also provide data-related services, such as we manage the New England Health Exchange Network, which is a separate organization responsible for bringing payers and providers together to exchange the kind of transactions that accompany insurance claims, whether it's benefits, eligibility, enrollment verification, and the like, as well as we've launched a data governance collaborative. That is a collaborative of payers and providers who are looking to advance interoperability and to stop information blocking as envisioned and articulated in Medicare's and the Office of the National Coordinator's final rules. So our work spans a range of areas. We work closely with Ray and CHIA to make CHIA case mix data available to organizations across the state via a web-based application that allows them to analyze the data while maintaining the level of privacy and security that's required. We're excited to be a part of the health data conversation today. There's a lot going on. I don't think any of us would have envisioned federal rules actually promoting a health data economy that was good for the industry, but it is indeed the case that we're moving to an economy, a health data economy, where sharing data will be the norm rather than the exception, and how we do it and how well we do it is critical to supporting a number of the goals that I mentioned earlier. So thank you for inviting me today, and I look forward to our continued discussion.
Great, thanks, Denny. And we'll wrap up the first question with Jim Cordobanch of Mass Health Quality Partners.
Hi, thanks everybody for inviting me. I'm actually here on behalf of our executive director, Barbara Rapson, who's away this week, but she sends along her greetings to all of you. So MHQP is an independent nonprofit coalition of key stakeholder groups here in Massachusetts working to improve the quality of patient experience through collaboration. We've been around since 1995. Specifically, we help providers and health plans and consumers and policymakers improve the quality of patient care experience in a variety of ways. First, we measure and publicly report non-biased, trusted, and comparable patient experience data. We also share tools and guidelines and best practices to help support improvement efforts. And finally, we also work to catalyze collaboration among all of our stakeholders to find solutions to shared challenges. And I would say that our work around this idea, our work is organized around the idea that the challenges facing us are best solved through collaboration across all the stakeholder groups. And I particularly mentioned patients, who we believe are the most underutilized resource in the healthcare system. Central to our identity is our relationship to our stakeholders. I would say that collaboration is foundational to us. It's built into our unique governance structure. We have 3 councils, a physician council, a health plan council, and a consumer council, each of which has equal representation on our board. In terms of funding, our funding comes from our stakeholders through membership, with additional funding from research grants, funded projects, and some data sales. So I will stop there.
Great, thanks very much. We'll move on to our second question, which is, how does your organization use data and/or evidence? And if applicable, recognize this doesn't apply to everybody on the panel, but if applicable, what data sets does your organization own, and which ones can you make available, and how do you do so? And we'll start this question off with David.
Great, thanks. So I'll probably be the shortest answer because I don't own any data sets or use. We do use a lot of data every year for going on almost 20 years now. The Massachusetts Health Council has produced what we call, we used to call the Health Status Indicator Report. We now call the Common Health for the Commonwealth, Health Status Indicators and Social Determinants of Health Report. That's a heck of an acronym. We're going to have to come up with something better. But what it really is it talks about the health status in Massachusetts of, so the obesity rate, diabetes rate, but also gun violence, poverty. So, we go through the social determinants of health, but then also the specific health conditions and things that can be improved upon. And typically, years ago, when before this information was at everyone's fingertips, we would release this at the beginning of a legislative session. Legislators would use it to craft legislation. They would note that, Massachusetts has, hypertension is particularly bad in some particular corner of the Commonwealth, based on the data that we're reporting on, not originating, we would gather this from CHIA or the Department of Public Health or Mass Health or any other entity that has access to the data. But we would formulate it and tabulate it in a way that made it accessible to legislators and other public policy officials, and include with it some kind of policy recommendations. In most cases, we would find the folks in our orbit, you know, from the Diabetes Association or the American Heart Association or the Mass Medical Society or Academy of Pediatrics, something like that, and ask them, what would you do to improve this problem, you know, that this data shows? And so legislators would use it like that. We should have released that report in roughly March, April of this year, and obviously got sidetracked with COVID and are waiting for an opportune moment to talk about it again. Because we do think, as I said earlier, COVID has revealed the flaws in our healthcare system, and that's part of what this report every 2 years also talked about is, you know, where are we not doing well? So I'll stop there.
Great, thanks. And Denny, in your opening remarks, you started to touch on this a little bit about how MHDC obtains and makes available data. So now you have a few more minutes to go into further detail about that.
Thank you, Craig. In addition to collecting and licensing data from the Center for Health Information and Analysis for availability to healthcare organizations across the state and the region, MHDC really has a somewhat unusual relationship vis-a-vis data in that we don't host or manage data directly as an organization. I would say we're really in the business of data governance. In a world where organizations are expected to be sharing data at a level that frankly makes many people in the hospital business or the insurance business uncomfortable, if you look at the historical or cultural traditions, if we want to call them that, that they bring forward today. But the reality is that in the absence of payers, patients, providers collaborating, there is really no way for an economy as complex as healthcare to deliver on any of the promises that it makes with respect to quality, with respect to safety, with respect to value, if you will, accessibility, equity. So our goal is to look at data as not an asset that each organization has special ownership of, you know, kind of the competitive nature of data, but rather that data is essentially like gas in the tank. Everyone has to use unleaded gasoline unless you're driving a 1957 Hudson or something. You have to use unleaded gasoline. The fuel that drives innovation has to be clean. It has to be consistent. It has to be replicable, especially as we move toward automation, where organizations are going to be sharing data, not so much in a centralized model, though those still apply in many cases, but increasingly in a federated model where what is necessary to be shared is available to other organizations who have appropriate access to individuals who have access to that. Many of you see the Apple Health application, for example, if you have an iPhone. And Apple Health essentially connects to any organization, healthcare organization, with whom you have electronic health data, who is compliant with the kind of data exchange standards that MHDC is supportive of. So I would characterize our data as we have a direct relationship vis-a-vis CHIA and promoting the use of those data for a range of purposes. But I would also add that, and as I've mentioned, our real position is in the role of data governance. How do you bring organizations together to establish the rules of engagement? How do you bring people together to understand what it means to share data? Under what circumstances is it a good idea, and under what circumstances is it not? And in that capacity, I think we're somewhat unique, but everybody has a stake in this. So I think we bear some similarities in many respects to all the organizations around the table. Thank you.
Thanks. So Jim, how does MHQP approach this question?
Great question. MHQP is primarily a measurement organization. So that's the primary use of our data. We collect, we aggregate, we benchmark, and we disseminate data to a variety of stakeholders. And I'm going to talk about a few of these data sets. The first is the data related to our commercial patient experience survey. MHQP has been surveying patients about their experience with a primary care for well over a decade. We have statewide adult and child results at the survey composite and at the question level. This data is used by health plans for risk contracting, used for quality improvement purposes by providers, and we publicly release it on our website, Healthcare Compass, with the performance benchmarks that we've developed. The state also incorporates our patient experience data in their annual report on the quality of care here in the state. Academics have used our patient experience data as well in their research. And a new thing that we're branching into is collecting patient narratives with the survey, where you pose a series of open-ended questions and the member types in the responses. And we found that this more qualitative patient narrative data tends to illuminate the quantitative survey results. I would also, on a side note, state that we also survey our Massachusetts Medicaid members on their experience, not just with primary care, but with behavioral health and long-term support and services. And these results are used for accountability by MassHealth. In addition to our patient experience survey, we've also, for about a decade, been collecting commercial quality HEDIS measures from the largest commercial health plans here in the state. We basically take that data and we aggregate that data across all the commercial health plans by measure at the practice site level. And we do some benchmarking with that data. The data, we've also, CHIA has used that data as well in their annual quality report, and we also publicly report that data. This data has also been licensed by researchers. And finally, I would be remiss not to mention the foundational tool for all of our measurement projects, which is our Massachusetts Provider Directory, known as the MPD, which is our provider hierarchy. Essentially, what the MPD does is assigns providers to practice sites, practices to medical groups, and medical groups to networks. We collaborate directly with health plans and providers to ensure that this hierarchy is as accurate as possible. And the MPD has been used by a variety of public and private entities. So I will stop there.
Great, thanks, Jim. So Ray, you started to touch on in your opening remarks the data sets that CHIA has. So maybe here we'll focus a little bit on the A in the acronym, what you do for analysis and analytics.
Sure. Well, it's such a hugely broad topic. I'll see if I can do it justice very quickly. I mean, CHIA was created in 2012, kind of in tandem with the Health Policy Commission to look at costs in the Commonwealth. And so that's one area where they do an awful lot of the analytic lift, although we do the data collection and kind of we generate the preliminary metrics. But at the time we were created, in addition to giving us that assignment, the state actually cobbled together a number of different data-intensive functions related to healthcare and put them in CHIA. So even though the agency was new in 2012, some of our functions go back decades in state government. So for instance, the hospital discharge database is something that our predecessor agency, the Division of Healthcare Finance and Policy, and prior to that, the Rate Setting Commission, there have been a variety of agencies that have been doing the functions that CHIA was assigned in 2012. So we're both new, but there's also a long continuity in what we do. So in terms of the in terms of the analytics that we do, it's driven in part by just these legacy assignments. So we do rate setting for MassHealth. We collect a lot of data from the provider organizations in the state, or at least anybody that does business with MassHealth, which is virtually everyone. And we use that information to generate rates. So that's hospitals, that's nursing homes, it's a whole bunch of different provider organization types. But but a fair amount of what we do is also discretionary. And I think that there's no way that you can't take account of what's just happened in terms of COVID-19 and just the renewed, or I think that there's a sudden intensity of focus around health equity issues that I think this time is going to be different. Just as a couple of years ago, if the topic was opioids, almost everything gave way, and kind of you put your work aside and you responded to the opioid request that had come down the line, because sort of nothing got in front of opioid questions, at least from a state government healthcare agency perspective. And I think you're going to see the same thing with health equity issues. So in terms of our analytic agenda going forward, I think we'll continue to see the regular focus we've had on provider finances, on collecting and building a great hospital discharge database and producing all the reports, or producing some of the key reports that are possible off of that, and then making it available to organizations like the Mass Health Data Consortium and others, and lots of researchers use that database for further analyses. We're going to continue to collect claims data and refine our all-payer claims database. That too is a multi-purpose tool. I mean, we use it for certain standard analyses, but it's really designed to be kind of an all-purpose tool for looking at not totals, right? Because it's not every claim in the system in an all-payer claims database, but it's a massive sample of encounters and payments in the system. And so using the all-payer claims database to study a bunch of different phenomenon. Our payer aggregate data that shows how much money is being spent and on what will be particularly important in light of the COVID pandemic. As will be our provider finance data. We've actually shifted from quarterly provider finance reporting to monthly provider finance reporting, specifically so that we can show more quickly the impact COVID is having on Massachusetts provider organizations. And the impact has been dramatic, but the interest in the reports has been very, very high. So that's an example of a type of report we've always done, provider finance reports, but we've changed the way we're doing it, and we've changed the cadence. We've increased the number of questions that we're asking, so that we can get at all the different types of financial support provider organizations have been receiving from the federal government and the state government, so that we can account for that in our reporting. So our analytic agenda is going to be a mixture of all the really good work we've been doing to date, and somehow layering on lots and lots of new work around the pandemic and around health equity issues.
Great, thanks. Paula, how does the coalition address data?
So Craig, like a couple of the other panelists, the coalition doesn't actually own any data sets that we continually develop and analyze. In fact, I think one of the interesting central issues in patient safety is that comprehensive measures of patient harm simply don't exist now and perhaps never will. But a crucial use of data is in our improvement collaboratives, where data is really a central part of how you motivate and support improvement among the participating teams and organizations. And then we'll build a database for each of those specific initiatives. So for an improvement collaborative, I think it's obvious that data can be used in a number of ways. First, in defining what's the metric of the ultimate goal for that team. How does an organization know that it's improving toward that goal? What progress it's making? So if we're reducing C. difficile infections, it's number of infections per 1,000 patient days. But we are asking the team to collect that. It's also important, we often have a balancing measure because as the team is working toward that, they want to make sure there's not unintended consequences. If you prescribe too many antibiotics, it increases C. difficile infections, but you don't want to miss treating some necessary infections. So you may want a measure of how many patients are ending up being sent to the hospital with sepsis from the long-term care organization. And then during the collaborative, we will share the strategies, the resources, teach the teams how to change behavior in the organization, how to see what makes it hard to follow those best practices, and how they might have some greater success. And then, as I said, we're asking the team to collect their own measures. We're asking them to track their progress over time, because that's actually also part of the way of motivating their improvement. They've had ideas of what they should change to improve their standard practices to be safer. And it can be very motivating to try to see that number change. At the same time, the coalition is collecting from all of the teams. So we're building a database specific to the improvement collaborative to say, who are we seeing here who's participating that's really showing some substantial improvement? And let's make sure they're sharing their story and their lessons learned with the other participants. And it turns out to be a much more powerful way than just necessarily one organization working internally, but it's all a database specific to that 2-year initiative. And then there may be a number of process goals. They may be tracking what are they successful in each of the individual changes they're making toward the ultimate goal. Then again, we're asking them to share that because we're looking for what are the most evidence-based, powerful changes. So our use of data at the coalition, it's never been automated collection and analysis. It's really been for recognizing what are strategies that are work, who has lessons to share. And as I say, that's one of the central challenges in patient safety. We ask people and try to teach them in an ongoing way how to use just enough data to support and maintain improvement. How can they track their own results over time so they don't lose those gains? How do they make sure they're maintaining those safe practices? So ours is a much more applied use of data in our work to date.
Thanks. We'll move on to our next question. So one of the subtexts of this conversation, and in fact how we even organized the panel, is the collaborative nature of the Massachusetts healthcare system, right? When we put these panelists together, it wasn't, oh, I've never heard of you. It was like a reunion. Oh, it's great to see you, because we work together so frequently on a lot of the initiatives you've heard discussed. So if you could please talk about how you collaborate with the other panelist organizations, with the state agencies, and with the general public. And Jim's remarks earlier, made me realize it's not just the general public, it's specifically patients and consumers and their family members that help them make healthcare decisions. So let's start off with Jim for this question.
Sure. I guess simply said, we collaborate with everyone. I would say that collaboration is built into our organizational DNA, which if you remember, I mentioned, this is really built into our unique governance structure that I mentioned. All of our work is informed by our stakeholders through our 3 councils. Again, it's a provider council, a health plan council, and a consumer council, as well as our board, and as well as other project-specific forums that we may convene. I will give an example of one project that we work very closely with CHIA about. We worked with CHIA on a number of measurement projects, but the latest was that CHIA sponsored our last run of our clinical quality HEDIS measurement. And basically we worked with CHIA and the 5 participating commercial health plans to figure out which of the HEDIS measures we want to report, how do we collect it, how do we aggregate the data, how do we do benchmarking. We shared this information, of course, with CHIA and with the health plans, but we also shared it with our stakeholder providers who used it for quality improvement purposes. And finally, both CHIA and MHQP publicly released this data. So you can see that we collaborated at the beginning and we basically released the data to all of our different stakeholders. I would also mention that even though MassHealth is not on, MassHealth is our local state Medicaid program. We have collaborated with them quite a bit over the past 3 years. We were selected to field 6 different surveys to support their the ACO program, and we had to develop 4 of those surveys because there was no survey that existed that could measure the program. I'd also be remiss again if I didn't mention that we were also users of data. We're right now in the middle, we're at the end of a big project where we're using the all-payer claims database, and I look forward to sharing those results with CHIA over the next 6 to 9 months. So those are some examples about how MHQP collaborates with our work.
Oops, Craig, are you?
Oh, sorry. Hi, thanks. Paula?
Thanks. Yeah, I think you'll recognize that Massachusetts has a long history of collaboration by the Mass Health Council itself. I recall being asked some years ago by some Texas organizations how they could create a collaborative working on patient safety, and I just thought, I bet Texas is kind of different. We have, as Jim and everyone is saying, collaboration is central to our work. As I mentioned, we work with RAISE organization and a number of our members and others who aren't members on how do we line efforts on improving care transitions and reducing hospital readmissions. We've often reached out to the Mass Health Quality Partners. More of our members are hospitals than physician practices, but we often have content that's valuable for physician practices, so we'll reach out and coordinate. And then a particularly challenging collaboration sometimes within our organization is our provider groups talking with the state regulatory agencies, truly with the intention of how do we maximize the improvement from state regulatory programs like in the Department of Public Health or the Board of Registration of Medicine. How do we learn from those so that it's not just improving within one organization, but across all organizations, as well as the opportunity to minimize reporting burden for the resources used. But in the coming year, I also had wanted to talk about something that our board is very excited about and take a quick lobbying moment. I mentioned that we've often worked toward a specific clinical goal, but we felt like we're not improving patient safety at a fast enough pace. In fact, I think a lot of people would say we're not improving on all our goals at the pace that we'd like to. So our board has been looking into what are the systemic changes within an organization that really help them accelerate their improvement and integrate performance improvement across all their goals, rather than just the overwhelming letting 1,000 projects bloom the way many organizations are, which is overwhelming their staff and overwhelming their organizations. So we've been part of the statewide organization that you may hear more about, but the Betsy Lehman Center within CHIA has brought together a very large group to talk about what are the activities that would really help improve patient safety. And we're excited about the opportunity to be working with that group to have that be how can we accelerate improvement across all goals so that it includes efficiency, it includes patient experience of care and workforce morale and satisfaction by helping organizations build improvement into their daily operations and not think that it's like a department out there. So the essential parts of that are how do you help people engage all staff and clinicians in the organization in understanding how to see and solve problems so that they are improving their work as they do their work. How can leadership help coach and support and keep that feasible and make sure that's not overwhelming? One of the things we're very excited about is if people work first on improving processes that waste time, if we're wasting staff and clinician time, that's not good for any of our goals. It's not good for safety or patient experience. So, and then as Jim said, and as numbers of people said, very importantly, how do we make sure that patients and families are included, because they're often the fresh eyes that are seeing problems, that have ideas for solutions. It's tragic to waste that resource, and let's make sure everybody is engaging patients and families in that ongoing work to see and solve problems. So for that, we're really looking to some key data for the future. I think there's going to be data about organizational change, and we'll all be interested in collaborating on how do we have these surveys where staff and clinicians are really commenting on, are they seeing the improvements in teamwork and safety culture that are improving operations and making it an enjoyable place to work and a safe place for their patients. And in the surveys of patients and families, are they feeling heard, not just about their experience of care, but when they see an accident waiting to happen, are their organizations really good at hearing them and responding to their suggestions? So we're looking forward to exciting developments with that continued collaboration toward that larger goal that's going to be crucial for safety, but we think crucial for healthcare overall. Thanks for the chance to lobby.
Great. Denny, how are you guys collaborating?
Well, as we've mentioned, as I've mentioned earlier, we collaborate a lot with Ray and the Center for Health Information Analysis. I think one of the things that stands out from our conversation today is we could collaborate more. I think one of the challenges, this is probably the most I've heard from our community as a community of not-for-profit organizations and agencies in some time. We each have, important and challenging goals to meet. And sometimes those goals can be ends in and of themselves, and we forget that we have colleagues who are working in very complementary places and whose services, whose offerings are, extremely helpful to us. Had I known, Jim, about your provider directory some years back, I would have been knocking on your door and getting that as quickly as I could. It would have been an invaluable tool for us. But I think, we're in a tough time where collaboration is difficult. We're getting better at it, as evidenced by, the meeting we're having today. But I think, we collaborate with many organizations. We share many of the same funders, boards, participants as other organizations in this call. But what stands out for me is that we probably could collaborate more. We have very complementary missions. We're not doing, and none of us are doing the same thing as the other. Our marketplace is too demanding to allow that to happen. So I think the fact that you have as many of us means that there are a lot of problems in healthcare that each of us are tackling based on our organization's DNA, our own, predispositions, our own interests. But the opportunity to collaborate further in the future, I think, would do us all good. So thank you.
Great. David?
Sure. Well, so as I mentioned earlier, we have our Common Health for the Commonwealth report, which is all about collaboration because we gather data from all these different sources, and then we invite different entities in the state to sort of comment on it. How can we improve this health condition, or how can we maintain the good status that we have, things like that. But let me, in a convoluted way, back into this, because I want to talk about something that I hope a lot of the folks listening will find interesting. One of the projects of the Massachusetts Health Council is something called student health clubs, right? High schools often have what they will call a student health club. If it's for kids who might want to go into the health professions of some kind, they'll join a club like that. They'll be guest speakers, they'll have projects, things like that. So the Massachusetts Health Council took on a project to sort of resource those existing student health clubs and encourage high schools to create them where they don't have them. And this has become particularly relevant now when so many schools are going remote and kids are looking for another, bands aren't meeting and sports teams aren't meeting. So start a student health club in your local high school. And the real opportunity for collaboration there is you now get all the different parts of the healthcare establishment to come and be guest speakers at this student health club. So these kids hear from doctors, nurses, dentists, biomedical researchers. They hear from the local executive director of a local YMCA, for instance, who talks to them about, here's how we really make health in the community, because we create the conditions where people can lead healthy lives. And YMCAs are one example of an organization that's at the center of that. So if you're listening, I'd be happy to provide you with more information about how to start a student health club in your state. You can take this on as a big project in your local community. It's a great resource.
Thanks. And Ray?
Right. Well, just to leave time for some questions, maybe I'll try to be very brief, but the question was, how do we collaborate with other panelist organizations? As you can hear, I think quite a bit. CHIA really believes that our data achieves its highest and best use when it's being shared. I mean, subject to all, privacy and other legal restrictions, but consistent with that, the more we can share our data, the better. So a bunch of private organizations represented on this call that you've heard, literally hundreds of researchers submit applications for and receive access to our case mix at all payer claims database. And so we do an awful lot of sharing with external parties, but inside of state government, really, it's kind of our it's in our DNA, to use the expression that Jim used. I mean, it's really, we're all about sourcing data to the Health Policy Commission, working with any other agency in state government that needs health data or can, benefit from the lens that we can provide into the operations of the state healthcare system. That's really what we, strive to do. So sharing data with public and private organizations is what we're all about. Another way of interpreting the question of how do you share or how do you collaborate is that we're learning we increasingly, it's not just a matter of handing people data and it's done. Increasingly, analytics and data operations are these intertwined activities. And when you go to do the analysis, there's inevitably something you wish had been thought about during the data collection stage. And as you're doing the data collection or trying to design the collection systems, there's always things you wish you knew about what they were trying to use it for. And so we're trying to increase those conversations and make sure that we're thinking about the analytics earlier in the life cycle of the data, so that we're not just getting 2 years into a data collection exercise and realizing that there are data elements that we aren't collecting, or we're collecting them in a certain way or what have you. So how we collaborate is also a function of listening to what people want to use our data for. So anyway, that's how we collaborate.
Thanks. So yeah, we've certainly filled the hour with some great discussion. But we probably have time for 1 or 2 questions. Reminder to please submit any questions via the Q&A application. And while we're waiting for questions to trickle in, I want to give a shout out to another Massachusetts organization, the Massachusetts eHealth Collaborative. For those who may have missed it last week, they were given the NADO Innovation and Data Dissemination Award. So certainly want to recognize their impressive contributions over the years to the Massachusetts health data community. I don't see any questions coming in. Everyone must have been extremely clear and comprehensive. Here's one. Okay, so I don't know, Ray, if you can see this, but do we know when CHIA will be accepting new private and commercial applications? We've been told the process for new applications has been put on hold.
Our website will have the latest news on that. I will say that we transitioned to remote work extremely successfully. One of the only functions that we need to be physically present for is that the APCD cuts are so large they can't be accessed online. I mean, it's not us, it's not our data users. Our most sophisticated users, their internet pipes would take a week to download the cuts they get. And so delivery of APCD data cuts is done via encrypted hard drive. And so we actually have to have staff people go into the office, get the cuts. There's a whole quality assurance process associated with the releases. So it's the thing that most involves putting our people into a risky position of going into Boston and being in the office creating these cuts. So that's like the only thing where we're doing some for critical internal stakeholders. I think we're getting to the point where we'll be able to start it up again for external stakeholders, but the website does have the latest news. It's it's been one of the most it is the most impacted function that we've not been able to move to remote. All of our workers are able to access data assets securely remotely. It's just cutting copies for external users requires that we go into the office.
Okay, great. Well, we're just about at the top of the hour, so want to invite everyone on the call to virtually join me in thanking all of our panelists for an exceptional discussion, and wish for continued success and collaboration in the coming years.
Thanks.
Thank you all.
Good to see all of you. Thank you, Nato.
Thank you, Nato.
Indeed, thank you so much.
Thanks very much,
Thank you
everyone.
for joining us. We'll see everybody at the next plenary in about 10 minutes. So see you over there in just a few minutes.
Excellent.
Thanks.
Great, thank you.
Bye.
Bye.
Bye-bye.